Hello, and thank you for your interest in this session, Managing Drug Diversion During a Pandemic. My name is Perry Flowers with Beck & Dickinson. I serve as Vice President in Medical Affairs. Bringing over 29 years of healthcare experience, I lead the Enterprise Medication Management Team within Medication Management Solutions Group of BD. Please allow me to introduce two distinguished colleagues and fellow presenters, Kelly Ropke and Donia Dumitru. Kelly, a nurse, researcher, and author, leads the thought leadership effort for medical affairs within BD. Donia, a pharmacist, researcher, and author, leads critical areas of enterprise medication management, also with medical affairs within BD. Both Kelly and Donia are experienced healthcare leaders in operations as well as specialty clinical practices, and welcome to you both. Before Kelly, Donia, and I begin this presentation, permit me, please, to send a heartfelt thank you to all those caregivers, frontline clinicians, first responders who are caring for the many patients needing care around the country, and to those caregivers in epicenters. I recognize those health systems that have answered the call to care, and thank you. Today's agenda for managing drug diversion during a pandemic centers around three key areas: a general review of drug diversion, a focused discussion regarding monitoring drug diversion during a pandemic, and finally, a focus on management strategies that this panel will present today. Please, a quick disclaimer. The information contained in this presentation is based on published guidelines as well as an internal clinical expertise. The implementation of this information is at the sole discretion of the hospital or health system based on established policies and procedures. Well, let's begin today with a drug diversion at a glance. While this infographic is full of information, you are welcome to pause the presentation and take a full accounting. But let me highlight a couple of areas in the hidden epidemic of healthcare. I'll start first with a quote from Rigo Garcia. Rigo and Claudia operate the Parkdale Center in the Midwest of the U.S. And Rigo, a CRNA, and his personal story is quite compelling. In his quote, "I broke my ankle playing baseball and for the first time in my life began taking prescription opioid painkillers." Now, I won't elaborate on his full story, and it's worth your, as an attendee's time, maybe for a quick look. He's got several YouTube videos. But even as a educated and intelligent and a qualified CRNA, began down that path of seeking injury to himself and certainly care for families. But that care in the patient environment really exemplifies that focus on healthcare's hidden epidemic. And whether a clinician comes by injury or otherwise, we certainly recognize that each of us face this in our own care practices. BD did commission a study recently that looked at this hidden epidemic. And a graphic in the middle of the page reviews a couple of the percentiles related to a couple of questions that were asked. 4 out of 5, roughly, of the respondents absolutely agree that there is a problem with diversion in U.S. hospitals. The corresponding value was only 1 in 4 believed it to be a problem in their facility. That gap is a part of the hidden epidemic. We know that pharmacy leaders across the country have taken this very seriously, and we've included a comment from Caitlin, who looks at the entire healthcare system as opposed to an individual location and describes the burden across the entire healthcare system of finding diversion, whether it's in an outlying facility or in the main medical center. And we know that that graphic includes a lot of discussion and peace when it comes to diversion, but we also recognize in a pandemic that there are extra emphasis on clinicians and their care environments. Kelly, would you share with the group some of your observations around diversion, clinicians, and maybe in this pandemic?
Sure. Thank you, Perry. As you may know, nursing work is both physically and mentally demanding in nature. It certainly isn't unusual to hurt your back, your shoulders, or experience physical discomfort in your daily activities of nursing. This can include bending, lifting, reaching, or simply being on your feet for 8 or 12 hours or more caring for patients. So not only are we at risk during the course of our work activities, but this can also make us more at risk for injuries outside of work as well. Mentally speaking, the stress and the emotions associated with nursing care of critical patients, of supporting the psychosocial needs of both patients and their families, and dealing with known issues that can impact nursing, such as workplace violence or bullying, are all factors that contribute to the psychological challenges in healthcare, particularly in COVID-19. We may be taking care of more patients as well during the COVID-19 pandemic crisis, either because of an increased surge in patient volume or decreased staffing, or both. And instead of working our typical 8 or 12-hour shifts with potentially 2 or 3 days of breaks in between to recover and rest, we may be working 16-hour shifts or longer durations and not having those sequential scheduled days off as we normally do, again, creating an environment that is ripe for risk. So all of these items that I've mentioned are exacerbated in COVID. We're already seeing stories of stress, of crisis in clinicians delivering health care. And we're also faced with additional burdens, such as gowning and gloving, such as proning ventilated patients in order to maintain adequate ventilation and oxygenation. And in many instances, nurses may be the only contacts that patients may come in contact with during the course of their care while they're in isolation. So all of these factors contribute to, again, the unique and significant risks for crisis that we're talking about today. We know that nurses have access to medications through the traditional channels of medication management, and nurses may experience injury or mental health challenges that can start the chain of events that we're talking about, that can lead to narcotic use that then morphs into substance use disorder. And in many instances, nurses will put their patients' well-being before their own. We do that regardless of whether there's a crisis or not. But in this unique circumstances and depending upon the individual experience, you mentioned an example by Rodrigo as we started our discussion, but at many times we feel a commitment to our teammates that regardless of injury, regardless of mental stress, we need to stay engaged even when we're suffering. And in times like these, it may be more difficult for us to find or request help that is both beneficial and productive and can lead to opportunities for diversion. So now I'll turn it over to you to continue the conversation.
Thank you, Kelly. As the COVID-19 pandemic has evolved, the impact on healthcare capacity has created surges in key medication management areas that have really challenged providers in ways unseen before. The rapid deployment of new on-site expanded COVID care units, coupled with non-traditional areas such as tents, hotels, and convention centers have posed especially unique challenges for diversion management. Of notable concern is that the focus on rapid deployment provides new opportunities for diversion, especially when normal controlled substances processes are either relaxed or deferred to accommodate the surge needs in new locations. With the opioid crisis still deeply affecting the U.S., statistics tell us that diversion will happen in these surge settings, potentially with even greater frequency than in regular care settings. This makes managing controlled substances an even more challenging operational process than usual, especially if new areas have more access that provides new opportunities in the context of different security procedures. Kelly, in terms of nursing practice, what other factors should we consider here?
So I think in terms of nursing practice, we need to consider the ease of access. We always have access to medications. We may see an increase in the volume and the type of medications that are now available to nurses. We also see a time of increased workload. Previously, I mentioned that we could be short-staffed for a number of reasons, whether it's patient volume related or whether it's short staffing. But in doing so, that creates the necessity for shortcuts and therefore risk. And it also creates an opportunity that has not existed before. And last but not least, I think it's important that nursing play a role in being a part of the solution in terms of what we can do together with pharmacy and our technology colleagues to ensure that we're managing at the top of our practice efforts to monitor, manage, and control potential risk for diversion that present risk not only to patients but also to the facilities we work in and to our own licensure. So as we look at this example, let's consider another scenario in how diversion can occur. So in the example provided in this slide, a nurse has found herself at the crossroads of narcotic misuse and substance disorder. And as the story unfolds, we see elements of stress in both the work setting and the home setting. This is typical to most of our lives in healthcare. But then there's an injury that occurs where a narcotic prescription has been provided, and while it was obtained legally and through necessity, it serves as a foray into another significant and dangerous issue, again impacting clinician, patient, and facility well-being and safety. So the scenario that's described here is one of access. The nurse is in pain and experiencing discomfort and stress. So the nurse begins taking medications that are actually meant for patients, a story of increased access. Perhaps she changes her method of diversion as she continues this practice to obtain more narcotics or to avoid potential identification. So the described scenario is presenting risk to patients. Is the care the nurse is providing safe? Is the patient receiving all ordered care as prescribed? Is the care being delivered on time by the impacted nurse? Is the patient receiving adequate medications to address their discomfort because the nurse is actually taking medications? These are a few of the things that are of the patient safety concern. We also noted that it presents a risk to the nurse. Does this put the nurse at risk for injury because of altered status? Does this provide an opportunity for, if caught, licensure revocation and therefore impact to just earning a living? And then, if we look at it from other angles, it can be risky to the clinician as well because there could be potential criminal charges and or prosecution. And last but certainly not least, the impact to the facility or the healthcare institution, particularly if the information becomes public. The institution faces multiple risks, including risk to reputation, safety, quality, and subsequent costs or fines associated with any adverse events, employee injury, and other factors. Perry, I'll turn it back over to you.
Thank you, Kelly. What such a powerful story and all too common. If we look at during the pandemic and the pressures that Donia and Kelly have described, it doesn't take long to fill an entire page of headlines that capture the impact during this pandemic surge. We could have taken your local newspaper and provided any number of different headlines. A couple below just frame the conversation that describes the very real need for medications during this pandemic time. But it also highlights that these are in short supply. The demand is increased, so the pressure is also escalated. If you're currently in a diversion situation where other measures are being taken, as Donia described, puts even more pressure on someone that is seeking. And looking at this demand, looking at the scarce resources, not only for controlled substance, but other meds that would need to be included in a diversion monitoring system. Donia, would you highlight some of those meds and some of the specific strategies?
Certainly. Thank you, Perry. As care needs have surged, so have drug therapy needs, especially for vented patients in the ICU. Hotspot hospitals have reported anywhere from 150 to 600% increased utilization of ventilator-related medications, such as propofol, fentanyl, and others. That has led to significant shortages in these first-line agents, requiring new approaches to supply chain management to ensure that patients have the drugs required. This COVID-related drug shortages problem, which is exacerbated an already existing baseline shortage in the market, has required new supply chain forecast tools, models, and approaches to plan for weekly, even daily needs in hospitals. One approach we've seen is the recognition that historical utilization rates of drugs will not help during a surge, moving hospitals to use other metrics, tracked daily, to more tightly forecast needs, and then be able to adjust drug procurement patterns and suppliers. For example, days of therapy for selected drugs, borrowed from antimicrobial stewardship principles, is one metric being used to help project immediate drug supply needs. The COVID-19 pandemic has created a broad-reaching set of challenges that healthcare providers must address and manage. In terms of operations, normal quickly becomes a memory and a later aspirational goal, as long-held processes are upended. Temporary caregivers, even from both out-of-state and shifted from other areas, must be quickly given access to ADCs and other equipment, as well as onboarded to new care areas and basic procedures. PPE conservation is a new phenomenon, and any and all processes that can be implemented to conserve gloves, masks, etc., are being put in place. This may require the temporary suspension of BioID access in favor of password access for some equipment. However, the goal is to return to BioID as soon as possible, recognizing that password access can be a diversion risk point. Also, due to the need to conserve PPE, adjusted medication management processes that minimize the number of trips to the ADC for restocking and other activities should be implemented. For example, increasing PAR levels of high utilization drugs, especially in COVID-19 areas. Kelly, we're just now starting to see the mental impacts this pandemic is having on our healthcare heroes. Would you go into more details about how that could affect diversion risk?
Sure. I think some of these factors we've established in our prior discussions, but I just want to reinforce that there's been a shift in nurse-patient ratios for a variety of factors or a combination of either increased patients or short staff. There's also been a redeployment of staff. For example, peri-op nurses may be working on med-surg floors or even in ICU in some instances, which is an unfamiliar work environment. So we know that the shift in staffing, the nurse-patient ratio challenge is creating stressors that can be a source of error, can be a source of risk, but create that sense of stress that is associated not only with COVID, but also with just taking care of higher acuity patients, not being familiar with the care strategies as they evolve. I think it's also important to mention that while nurses are directly at the bedside, they're exposing themselves to risks of infection as well, and also bear the burden and the fear associated with potentially bringing that home from their work environment and potentially transmitting it to their families as well.
Thank you, Kelly. As our government and regulatory agencies have rallied to support the pandemic, we've seen a number of rules and requirements relaxed to help preserve the supply chain for direct patient care. States have waived new licensing procedures, especially for out-of-state providers that are volunteering in surge areas. And we've also seen, for example, the DEA issue temporary policy changes, such as licensing and drug distribution quotas. Perry, given this truly unique situation on so many different levels, what do these factors mean for diversion management operations?
Donnie, I look at the quote here from the DOJ and the DEA, and I see from a management perspective, the one key word that jumps out is exception. And we're all applaud the DEA for their quick action, but when it comes to looking at the management of diversion and diversion risk, any variation and exception to those pathways certainly exposes a risk to the organization and to leadership. When we look at these exceptions and we look at the variation, it certainly prompts us to look at some management strategies during the pandemic and beyond. Kelly, I would like you to take a stab at the medication management considerations from your perspective, looking at care delivery.
Sure, thanks, Perry. We know that access to use for narcotics can be an issue with diversion. We've talked about increased access. We've talked about shifting formulary in the medication supply that is meant for patients on COVID units. In COVID-related care environments, nurses may now have access to a higher volume or a percentage of the formulary and more inventory or types of narcotics in terms of delivering patient care. Ensuring count, waste, and discrepancy processes are in place and being followed is essential to ensure patient and employee safety at this time of uncertainty, of evolving practices. We have best practices in place. We need to follow them. Reinforcing the necessity to follow through on proper medication dispensing workflows is very pertinent to what I'm talking about. If we take out 2 vials and need to return 1, we need to ensure that that vial actually gets returned properly versus stays in our pocket or is potentially diverted. We also need to ensure we're closing out our waste workflows, particularly when they require witnesses. And what we're really getting at is ensuring that the documentation loop of the activities that in care that we deliver to our patients are addressed and are reflected in subsequent data for analytics purposes. Nurses can also use web-based features associated with medication management technology that allows us to perform proactive workflow initiation at the bedside or where it's most convenient to allow us some time management and or consolidation of activities when we leave the bedside that allows us to not only initiate quickly, but also complete those documentation activities. And this includes, again, waste. specifically, I think I want to spend a little more time talking about waste. In times of intense infection control measures like this, where we're gowning and we're clubbing in order to enter a patient's room, where we're minimizing access of multiple care providers, it's already a challenge when we talk about a waste witnessing event, particularly when we're busy. And we've talked about how busy these units are. But locating a witness and completing that documentation, or even just doing a waste without a witness, honestly can be deprioritized or even omitted depending upon the intensity of work, the acuity of patients, and the urgency of events. But we must be and continue to support practice where we're diligent in our responsibilities, not only to complete our documentation and to ensure a proper chain of custody throughout the medication management workflow, but we're also partners assisting our pharmacy colleagues with maintaining best practices and, again, supporting that safe patient care we've been talking about. And then finally, I would say, we're all used to counting of narcotics on units as part of our everyday nursing workflow in normal times. But I encourage our audience today to consider using blind count features or other count features available within medication management technologies that can enable real-time activities that help manage or alert to inventory discrepancies and support what works best in your environment as far as count and discrepancy management occurs, but utilize your technology to support your workflow changes.
Thank you, Kelly. Continuing on those themes that you touched on, in terms of inventory monitoring, I'd like to place some additional emphasis on some of those themes. A primary rule of thumb is to recognize that the basic tenets of controlled substances management will not change. Counts must still balance, discrepancies must still be accounted for, chain of custody must be documented throughout the controlled substances handling process. During ordering and receiving documentation, and processes must remain intact. Recognize that once the current crisis abates, regulatory controls for these basic areas will remain high priority focus areas for law enforcement and regulatory agency inspections. Prepare now, to the best of your ability, for those audits and inspections of the future. Let's look at some examples. If a surge area utilizes ADC technology, standard controlled substance controls at the devices should be deployed to the new areas, ideally mimicking the sponsoring hospital's ADC settings. If the surge area utilizes floor stock cabinets, implement paper controlled substance documentation tools to preserve the chain of custody accountability. Spot checks and random audits, even if briefer than in normal operations, are both important deterrents to diversion and help meet regulatory requirements for a diversion management program. Special attention and perhaps even enhanced staffing levels should be placed on non-traditional surge areas such as tents or convention centers, as they will likely not have the usual video and other security equipment in place to augment any deterrent activities. Be especially in tune and vigilant to spot new methods of diverting in these situations. Another reason to ensure that audits are done in these settings. Perry, can you touch on some tools that can help with these areas?
Thank you, Donia, for that, and Kelly, for those management considerations. We need all the help we can get, as you've heard Kelly and Donia describe, looking at the technology and the analytics to support a proactive diversion. BD does offer health site diversion management capabilities. Regardless of what analytics you use, I would highlight a couple of areas to really focus on during this pandemic time. Specifically, the reporting and the reconciliation. Both Kelly and Donia highlighted the areas of personnel and their alternate work site locations from a clinical practice as well as physical location, as well as the need to reconcile inventory management as well as the waste streams. Focusing on those two areas in a timely effort will certainly warrant management discussions around highlighting and focusing on those diversion risks. For the longer term, I would offer the thought around a risk scoring and the investigation. The risk scoring would be highlighting against peer groups, would be highlighting against similar patient demands. And then finally, the investigation. Skilled and trained investigators are certainly a key and will be needed in the long term post-COVID, post-pandemic. I mentioned briefly the diversion management capabilities that BD offers to look at unique scoring and providing analytical trends on risk and risk scores that would again be an example of technology and analytics supporting management in their overall obligation for diversion awareness. We've covered a lot of different categories today around clinical and clinical concerns at the practitioner level. We've discussed management capabilities and the need for technology supporting management's efforts. We've been able to highlight a couple of additional resources that are available to you. Would certainly highlight BD HealthSite's diversion management can be found through our link MMS COVID that's being displayed. We've outlined a couple of industry associations for your consideration, ASHP, ISNP, and certainly our National Council of Boards of Nursing. Also highlight several of those that are at the federal and state level in support of diversion awareness. On behalf of Kelly, Donia, and all of BD associates, thanks for each attendee's time and your expertise caring for patients. Thank you.